Good evening, friends. Namrata, is visible?
Yes, sir. Perfect.
Yeah. First of all, I'd like to thank AIOS team and the JICE people for organizing this wonderful session on digital technologies. I think entire surgery, not only the ophthalmic surgery, most surgery done in a body has become digitalized, and we are not far behind in improving the outcomes of various ophthalmic surgeries with digitization. So I'm going to talk about the workflow of cataract surgery with new digital technologies which we have with us. As far as financial disclosure are concerned, I have no financial disclosure to be made. We have been employed by the government sector, All India Institute of Medical Sciences. Let me take you through this presentation in three segments. So if you look into workflow for cataract surgery, there'll be three things. One is the pre-operative assessment of our cases. And what about intraoperative features with digital systems? And ultimately, the post-op assessment for looking for outcome, satisfaction of our patient after doing surgery. So let me take you the first thing, which is basically the work of a patient, which is now become so accurate with optical biometries and the aberrometry analysis of these patients. Then, most importantly, the data transfer of these diagnostic to the operating microscope for your surgical enhancement. So effectively, we can say today the cataract surgery has become like a refractive surgery. It's mainly because of availability of these technologies, which made things possible for us to calculate in a manner which will give you ultimate results. So this is how I'm going to take you through the initial things, which will be basically looking for IOL Master 700, ray tracing of cataract patients to get aberrometry of the eyes, and how to get the data transferred to have a surgical precision and accuracy in the operating table, and the final outcome in the post-op period. IOL Master 700, we all know, is the latest technology in optical biometry, which gives a telecentric keratometry to give you a better assessment of a corneal as such, and the attachment of swept source OCT, which provides the total K, which also encompasses the both anterior and posterior corneal curvatures. We all know posterior corneal surface has become very important since we have been working on a toric IOL outcomes. Now we know that posterior corneal surface has to be assessed to achieve a good outcome in a toric IOL implantations. Once we have a Surf OCT attached in ILMaster 700 that effectively calculates the entire both anterior and posterior surface, gives you a total keratometry, which is basically takes away the calculation which were made initially to presume how much will be the effect of a posterior corneal curvature in ultimate IOL power calculation. So that's the advantage of having combination of IL Master, which has telecentric three-zone keratometric assessment of anterior cornea. With the OCT, you get a nice posterior surface assessment of these cases. And TK will give you a better assessment for, especially for IOLs power calculation, which are looking for cases with toric IOLs. And especially now with the trifocal toric lens, so you require a very accurate assessment, and most importantly, the post-refractive surgery patients where we do have major challenge of assessing the corneal toricity or corneal power more accurately, because after refractive surgery, both anterior and posterior corneal curvature would change. And the tools which we had earlier may not give you a true analysis of posterior curvatural change after refractive surgery in these corneas. So this IL Master 700 gives you a true K or a total K, which will give us a good assessment of IL power calculation in cases of post-refractive surgery patients. So if you have IL Master 700 as an interface, what all things is can be used to get a good outcome in your patient. So basically, it is the integration of pre-operative assessment with IL Master 700 and transport this data to the operating table. So basically, it is an Ethernet port which is connected, internet connected with the system to the printer, and the software can also be there. The data interface is electronically can be transferred to your operating system, especially microscope, where it can be computed to assess your Callisto eye. So the toric eye alignment can be easy. So either it can be transported by your USB port, or you can have a forum attachment where you don't require to take any data with USB. That is that makes the surgical area much simpler. Your workflow can be much simpler, and no disparity. Sometimes you can have multiple image data in one system, and that can confuse sometimes your toric calculation also. So I would say if you have a forum, that makes things better in terms of managing your workflow in the OR. The second important thing, digitization of a pre-op worker would be assessing the abrometry, especially looking for a angle alpha or angle kappa. Angle alpha will be much more important for a IOL implantation, both for a toric as well for a multifocal or trifocal lenses. So if you have patients with a high angle alpha, which is more than 0.5 millimeter, so these cases may be poor cases for a premium IOL. So this will sort out the patients which can have a post-op poor vision, especially they can have visual symptoms like halos and glare and starburst. So that can be avoided in these patients. So this has become an important assessment pre-operatively for all patients nowadays. The second important part of a workflow would be after you've done a good assessment of your patients clinically in a pre-op section, the data has to be transferred into an operating microscope. So what all things we can do there? So we have image guided systems attached, like Callisto in a JICE system, or you can have attachment of integrated intraoperative OCT, which can give you a true dynamicity of changes happening during your surgery. It can also give you sections of your structure, so you can know what morphological changes you are seeing in your patients, especially if you're doing a cornea or retina surgeries. It is also useful for cataract surgery also. You can have intraoperative abrometry based calculation of IOL power or a toricity or a toric alignments. And what we just heard the previous talk on the digital microscope, especially 3D heads-up surgery, which can also improve your outcomes to have a good post-op picture in these cases. So I would take you through the important area of cataract surgery, that is toric IOL implantation. We all are doing toric implantation for our patients because we know that anything more than one diopter cylinder in the cornea can cause a post-op poor unaided vision in your patient, and that can be headache for a patient and for a surgeon also to explain why vision is not 6/6 without glasses. The toric IOL significance is there because we always have around 30 to 40% of patients will have at least more than one diopter cylinder, especially if you have a multifocal or a trifocal cases. This toricity, less than one diopter also should be corrected with toric IOLs. So basically, we have been taught we are going to see the astigmatic axis of patient in pre-op factor. The amount of astigmatism is with the rule, against the rule has to be seen. And on the table, you have to mark the axis, both reference and implantation axis accurately if you are using manual. But if you are using a alignment with systems, can give you image guided surgeries like Callisto I G Align or a Varion. These are two important systems we have nowadays in OR, which can help you. Or you can have intraoperative abrometry devices. We can also enhance the outcome for your patients. So classically, we have been doing a three-step procedure that is going to give, as I said, three reference marker, then intraoperatively axis marking for these patients. And image guided modalities now we have. So if you see the various results analyzed in the literature, they would say visual acuity is always comparable with the various types of devices used for marking the cornea, and even with the image guided systems also. But if you look at the visual quality, which is the actual assessment of outcome of these lenses, is not well known for most of these cases with various devices. So these are various devices used for image guided systems. You have Osher's eye trace system can be used. As I said, Varion and Callista are the one which are using very regularly, and most people are using these devices. You can have ORA or OptiWave refractive analysis by Alcon, which is a based on an intraoperative wavefront refraction to calculate the power and see the alignment also. Just to show you what are the tricks we play in the operation theater. This is a patient under Artigo. So image guided system will give you a accurate incision placement for a main as well as for side port. And that is important because sometimes SIA would change if you change your incision. Never change your incision as per the axis. Maintain the same axis for a toric IOS because the toricity is going to be corrected by IOL, not by your incision. This also helps you giving a good capsular exercise and centration, and that will be effective for placing lens effectively in a proper position. So once we complete the nucleotomy safely, you can have cortex aspirated. You all know for any IOL implantation, proper cleaning of posterior capsule also important. Viscoelastic has to be removed effectively both from anterior to the lens and from the posterior to the lens surface also, because the rotation post-op can be mainly sometimes because of a retained viscoelastic. So these three marks which you see with the jet aligned Callisto system is the central one has to be aligned to the three dots which are there in a optic haptic junction eyewear. Always keep the lens little away from the central area, anti-clockwise, hydrate the wound, make the chamber stable, then just tuck these lens to get these three dots in the lens to align with the center line of a Callisto images. You can see nicely centered images with the line. So this will effectively improve the outcome for your patients. But sometimes these lenses, especially open loop L-shaped haptics, are difficult to rotate anti-clockwise. So you have to make sure lens is well open. I can see that my axis is 111 degree here, well aligned. I'm hydrating the wound area. So sometimes during this procedure also lens can move. So it's gone away from my area. So I can't rotate reverse. I have to rotate entirely 180 degrees to come back to the area. I'll leave it little anti-clockwise, then subsequently place the lens after making a complete watertight closure of your chamber. To make sure you remove entire viscoelastic, maintain the antechamber integrity, then tap the lens in a position from the anti-clockwise to clockwise. So this is what I want to show people, that manual marking can be haywire sometimes. It is almost 5 degrees away from the desired axis. So I'm putting my own way to correct the orientation here. The marking has to be sharp and as clean as possible. If you have a wider mark, that can also take away your 1 or 2 degrees. So this is a sharp marking here, which is matching with the Callisto marking here. Now after surgery also, you'll see manual marking and the Callisto marking is also matching. So if you want to use only manual marking, you don't have image guided system, you can still achieve a good results, but you have to have a consistent marking by an experienced person in a patient. And especially if you have a 3 reference marking, that will give you a much better alignment and may take away the torsional effect also. This is our initial result of comparing manual versus image guided surgeries. And we found that image guided surgeries would be definitely better. So this was a group 1 manual marking and group 2 Callisto marking, and had a significantly better relation of post-op assessment with eye trace, looking that in image guided system, we had lesser deviation from the main axis in these patients. And the other important thing was visual acuity were comparable, as I said in the beginning also. But once we looked into a modulation transfer factor function, which is basically the contrast of these patients and point sweat function, both were effectively much better in case of the image guided surgeries. That shows that if you are nearer to your reference axis or implantation, your quality of vision of patient will be much better. This is a device which is attached to a femtosecond laser. And you can see here, this device gives you a little knob in the capsulotomy, and that can be a reference axis or implantation. So laser devices can also give you an enhancement of placing IOL in an accurate axis for these patients. This is one of our patient which is correctly aligned to the tongue, which is there in a refractive capsulotomy, and IOL can be implanted subsequently. Comparing Callisto versus Aura, and there are many reports out there. Callisto and Aura are equally good, but some studies would say Callisto will be better in some cases also. What about workflow with Artipo 800 3D operating microscope? We heard Dr. Garewal taking us through the entire system. This is also a significant increase in the safety of yourself, patient, and getting a good results. This is our editorial we published in IGO, looking into its advantage in a current normal of working in a COVID time. We do have 3D system, active or passive. What we use is a passive 3D system where we use a heads-up system. We have two available in India, Ingenuity and RTVO cases. So this is what Dr. Garewal talked about. You can go to very, very high magnification of these patients. My illumination around 36%. You can see 17.5 time magnification. And despite this magnification, the image doesn't get distorted. Only thing, the movement of eye or patient can be magnified also. So you have to be careful little in these cases. So this is very, very advantageous. If you have a complication like PCR, you can see better and you can manage better in these cases. Second advantage is it also has Callisto aligned attachment. So after IOL implantation, especially for a multifocal, trifocal toric lenses, the alignment can be better done in these patients effectively because you have a larger screen to see and you can do better. Third is had an OCT attachment and difficult cases like a white cataract. You know that what type of white cataract you are dealing with. You can assess the intraoperatively, what type of fluid release you have, how much is the pressure release after your initial nick, all can be assessed with your IOCT attachment. The most important thing which I have seen is the patient, which Dr. Garewal talked about, the illumination in a topical anesthesia, patient may not be comfortable at all. You can see if I decrease my illumination, I can go even up to 5% illumination to make patient see better. You can see I'm going down now, working with a 5% illumination, patient now fixes and you can do a surgery comfortably. So that's the advantage of this system with this microscope. If you look into a Callisto system, because it is magnified, so you can see these three lines of Callisto, which is, you can say, minified in your screen. So this will also improve your precision in implantation of toric IOL because the lines are narrower. Your alignment will be much better in these cases. To compare Ingenuity with Artipo, Artipo is a integrated system which has a lesser lag than a Ingenuity. Therefore, it is a better system for anti-segment surgeries, though both are equally good for posterior segment surgery also. As I said, for a COVID time, the surgeon is also away from the patient's eye, and the residents can also sit at least 2 meters behind, and they can effectively see the entire surgery without creating a crowd in the operation theater. So that's a very good system in a COVID time also. And it's a unique in terms of ergonomics, which Dr. Garewal talked about. You are absolutely straight viewing the system, but there's a little bit angle from head to eye. This you get used to within a few surgeries. The only problem maybe is the assistant can have a larger angle for adjusting. And sometimes the sisters can have a little difficulty if you put the lights off. What about digital workflow in a post-op period? That is basically when looking of ray tracing aberrometry, toric enhancement softwares, which can also improve your quality of your assessment of post-op cases, especially with toric IOS. So this is what we use, iTrace, to look into your patients. Like this patient would require a rotation of 74 degrees, which will improve your cylinder effectively to a 3.14 diopter. So these type of things doesn't happen. This is a rare case which can happen with a rotation, a high myopic patient with a bag is large. So these cases you have to reassess, then subsequently rotate these cases. This another patient shows 25-degree rotation. The patient has a good visual acuity, 20-25, and shows that if you rotate, only 0.5 correction will be there. So you have to take a decision on this. Sorry. This is one patient, effectively no rotation required, 1 degree. And this is a software which is available with, www.astigmatismfix.com. You can analyze similarly in these cases also. To summarize, toric IOL, the prerequisite for in the digital time also is manual methods may not be good, but pendular methods are equally good. Image guided systems have really given a way for accuracy for our patients. Intraop abrometry may help in some cases, especially post-refractive surgery cases. 3D head-swab display is helpful for surgeons. Sorry, with the enhanced ergonomics, especially the magnification, working with the OCT and toric image guided systems does help you in improving visual quality. Residents, I think, as Dr. Garewal talked about, it's very helpful for teaching. A large number of people can see at a single time, and they can assess themselves, seeing the surgeon, and improve their surgery also. The institution where we have more teaching, these devices are seems to be a must in future. For nursing staffs also, they can see the surgery, what is being going on, and they can assess better. But sometimes if the lights are dim, they can have difficulty in, especially they're loading the IOLs. Digital outflow improves the workflow for our patients, both intraoperative, where we have advanced diagnostic like IL-Master 700, which gives you formulas which can effectively be used for difficult cases like post-refractive surgery patients. Ray tracing abrometry. Interoperatively, they can be integrated to an image-guided system, IOCT, and abrometry. And basically, the entire pre and intraop can be integrated by seamless transmission through forum. And post-op assessment is also digitalized nowadays to get a good results for our patients. Thank you for kind listening.